I'm Dr. Sravya, going to present a paper on study of spectrum of cavernous sinus syndromes in tertiary care center. Um, Coming to the introduction, cavernous sinus syndrome is characterized by ophthalmoplegia, facial sensory loss, Horner syndrome, and due to its diverse etiology and non-amenable site for biopsy, detailed history and clinical examination and with supportive radiological findings helps in narrowing the differential diagnosis of the cavernous sinus syndrome. The study, coming to the methods, the study was carried out at a tertiary care center in Western Maharashtra. The study was a prospective observational study with patients recruited over a period of 10 months, and a total of 30 patients were included in the study with findings consistent with cavernous sinus syndrome, as in involvement of more than 2 cranial nerves, 3, 4, 5, 6, or any one of them with neuroimaging confirmed lesion in the cavernous sinus. Coming to the results, a total of 30 patients were included in this study, of which 44% were males and 17%, 56% were females. The mean age of presentation was 50 plus or minus 5 years. Coming to the clinical presentation, diplopia was the most common symptom, followed by headache. And coming to the clinical examination, the most common cranial nerve involvement seen in this study is abducent nerve, which was seen in 28 patients, that is about 94% of the patients, followed by oculomotor and trochlear nerve. Then 15 patients had trigeminal, that is 50%, and optic nerve around 35% of the patient had optic nerve involvement. Coming to the radiological features, about 26 patients had post MRI images showing post-contrast enhancement, and about 12 patients had orbital apex involvement, extension into the orbital apex from the cavernous sinus, and about 10 patients had pansinusitis in imaging. And coming to the etiology, of the total 30 patients, 15 patients had infectious etiology, of which coming to the infectious etiology, of the 15 patients with infections, 7 patients had mucormycosis, and 5 patients had invasive aspergillosis, and 3 patients had tuberculosis. All these 15 patients had underlying comorbidities. This is the figure showing cavernous sinus syndrome, cavernous sinus hyperintensity, post-contrast cavernous sinus enhancement. Coming to the other etiologies, followed by infectious, about 26% of the patients had tumors, direct tumors in like 10% patients had direct tumors, and 16% had metastatic tumors, and followed by tumors. Tulsa Hunt was seen in about 13% of the patients, that was 4 in number. All the 4 patients had orbital apex involvement, and followed by Tulsa Hunt, 3 patients had vascular cause, that is keratodo-cavernous fistula, and 2% of the patients had other etiologies like vasculitis. These are the different figures showing post-contrast enhancement of the cavernous sinus extending into the orbital apex. This is a diffusion image showing high value in diffusion, showing diffusion restriction. Coming to the clinical profile of the patients according to the different etiologies, presence of severe sensory visual loss was associated with fungal cavernous sinus syndrome. Presence of proptosis was associated with vascular, that is keratodo-cavernous fistula, which was usually associated with the bruit, which is a classical sign for the keratodo-cavernous fistula, with proptosis and redness, which was seen in 2 patients. That's a very important sign to delineate the etiology of the cavernous sinus syndrome. Coming to the presence of diabetes was significantly associated with fungal cavernous sinus syndrome, and bilateral etiology was significantly associated with vascular and tumor etiologies. And the presence of other cranial nerve involvement, lower cranial nerve involvement, was more associated with fungal infections causing skull-base osteomyelitis. Coming to the radiological profile, pansinusitis with bony erosions were more suggestive of fungal infections, and prominence of superior ophthalmic vein, which is a sign of keratodo-cavernous fistula, which was seen in all the 3 patients with vascular etiology, and orbital apex extension is seen in all the patients with Tulsa Hunt syndrome. Coming to the discussion, we have compared our experience with other studies delineating the diverse clinical presentation of predisposing factors and etiologies. In all the previous studies, they have found that tumors are the most common cause for cavernous sinus syndrome. But in our study, we found almost 50% of the patients with infectious etiology causing cavernous sinus syndrome. Coming to the conclusion, cavernous sinus syndrome is an important cause of acute onset external ophthalmoplegia. Because of its diverse etiological profile, careful examination is important to rule out the treatable causes like infectious causes and vasculitic causes. The prevalence of infection is in our study was much higher, which is inconsistent with the previous studies, but this can be attributed to the high prevalence of infections in India. Presence of diabetes with radiological evidence of bony erosions and paranasal sinusitis should raise a high suspicion of underlying fungal etiology, which is the most common cause in India because of the high prevalence of infections. Thank you.